Yes, now I would like to invite Mahesh sir. Mahesh sir needs no introduction. Sir is the head of the department Retina Girdhar Eye Institute and president KSOS, past
Immediate
president.
past president.
Yes, immediate past president KSOS. So we'll be talking on surgical management of infective uveitis.
The biggest problem in uveitis is we have to give steroids. We are not sure whether it's infective. So I will give one clue. If you want to rule out TB and you are sending to pulmonologist, if the MANDU is positive, so they will say there is no evidence of tuberculosis because they will do some tests. So don't write that like that. He is having a choroiditis. We are going to give high dose steroid. Kindly advise regarding fitness since his MANDU is positive. Just write like that. Then they will probably properly treat. This is one technique. You can all practice this. Otherwise, you see, they will do, there is MANDU positive, other things are negative, no need of steroid. So this is the best method. So that is, okay. So this is surgical management. I don't have much of experience, but because our uveitis department is managing very well. Uh, the diagnostic surgical procedures are aqueous tap or vitreous tap. Both are used. Aqueous tap is very easy. You can do easily. Vitreous tap is mostly needed. The tolerance to tap is very less now. Immediately uveitis comes, we want diagnosis. Initially what we used to 25 years back, we will give steroid, then we will wait. If it is ultimately when it is getting bad, then only we will think about all this tap and all this stuff. And now the molecular diagnostic PCR, everything is available everywhere. So that has improved the results and the need for vitreous tap. So the second indication for surgical management is therapeutic indication to manage complications, to clear the vitreous debris after the things are gone. Then the most important thing that I come across is RD in acute retinal necrosis. So there are other surgical treatment needed if there is a complicated cataract or secondary glaucoma, which I am not going to cover. So this is a case, 64-year-old came with a hemorrhage in the macula. It looks like a CNVM, and Avastin was given based on this OCT picture. There is a strum in the central area, subretinal hyperreflective material. It was thought that it was a classic CNVM. 1 week after injection, it has become like this. There is an abscess there. So it is not due to the Avastin that has resulted. It is a misdiagnosed the initial picture. It was looking very harmless thing. So it was a abscess in 1 week, and we did all investigation. Vitritis was there. We did systemic investigations, and then vitreous biopsy was done. So vitreous biopsy is a simple procedure. You can do it single port with 23 gauge. You don't even need that suturing. So here this is a old picture. Again, yeah, it is not working. So important thing is once you start aspirating with cutter and suction, before you remove the cutter outside, you have to clamp the tubing. Otherwise, this fluid, whatever you have aspirated little, will go to the tubing and you will not get any sample. Another thing is, if you are going to do a proper vitrectomy also, if the vitreous is very hazy, you are going to do a proper vitrectomy, you can have 3 port. With in 1 port you can switch on air so that fluid is not mixing. Under air you can do little vitrectomy and then switch on the infusion. So this is a simple procedure, and we are getting lot of positive results. This patient which I showed had excitone was positive for TB, and patient had incomplete treatment long time back, started on steroid. This case we lost. In spite of all these things, it became phthisis. So that is so this case I wanted to show just because to show the importance of vitreous tap. Now acute retinal necrosis is the most difficult surgical treatment. Why it is difficult is there will be multiple breaks, sieve-like break across the retina. there will be severe fibrosis after laser. When it heals, it will be totally fibrosed, a lot of membranes over the retina, and many times you can get hypotony also. So this used to be one of the indications for high density silicone oil, which we cannot remove for a long time. So this is a case which I operated. Patient had acute retinal necrosis and it healed, and after 3 or 4 months patient had RD involving the macula. The lower part, you can see that whole area, atrophic area, it has multiple small holes, and it detached, including macula was detached. So the most difficult problem here is to induce PVD. There will be nothing, actually a struggle for half an hour, and put the triamcinolone on and then try to peel it. I made couple of breaks, and with the forceps somehow managed PVD in at least in the other areas, and shaved the vitreous and put silicone oil. So this is a very difficult surgery. Whichever case, this case underwent the oil removal later, but many times we will not be able to remove the oil because of the hypotony and fibrosis. It will redetach again. So this is just shaving all other areas. By the time PVD was induced, it had become bullous. So extremely difficult PVD induction. So this is some points that I thought I can share, and then after silicone oil. Okay. So this is the usual standard treatment for AR and retinal detachment. We use 5000 centistoke oil, which emulsifies less, and we can keep it for a longer time. Then I thought one more patient I can share. This was a patient with defective vision, and OCT revealed loss of ellipsoid line in the left eye, and all the areas had ellipsoid disruption, and this was the fundus autofluorescence, plenty of pigment disturbances, and this was the angio with multiple leaking areas, and in one of the sections you could see a small worm in that area. So this is another thing that we can, so this is a worm in that area which was moving around. Laser was given. Once you start laser, it started moving. So I went back behind the worm and then gave laser. That is the worm going that way, and then ultimately killed this thing. So this was the, so this is laser, but sometimes you can get it follow-up OCT. There was recovery of the ellipsoid line, but vision was not improving beyond 6/60. So this is follow-up. So this is another case which was treated that the design is not because that I made it, because it was moving around. Okay. So and sometimes you get it into the vitreous cavity. This is a dead worm. Then I could not get my video. Sometimes you have to go inside and remove the vitreous along with the worm. So this is another this thing. The last part is endogenous endophthalmitis. We get not many, some people get lot of endogenous endophthalmitis. This was a patient on dialysis for diabetic nephropathy, sudden onset of defective vision. So granulomatous uveitis, cells in front, behind, and patient, this is the B scan, already bad, patient was very sick. So intravitreal voriconazole was given based on the central line culture which grew candida. This luckily we could save this eye with the systemic and oral treatment. So nowadays for endogenous endophthalmitis also the it is little aggressive. Immediately do vitrectomy and diagnostic test for vitreous cavity. So these are some of the surgical indications for infective uveitis. Thank you very much.